Navigating through heart disease, it can feel lonely and scary. Oftentimes, the first person you'll meet is a nurse practitioner. Today, I sit down with Julie Krasner of UCLA. She's a nurse practitioner with over 40 years of nursing experience. She's an RN, MN, CSN, and CHFN, meaning she is a certified heart failure nurse. I hope you enjoy my conversation with Julie Krasner of UCLA. So, for anyone watching this, what truly can a patient learn about working with their nurse? What are different things that a nurse would offer them?
A nurse offers them communication. A nurse is going to offer them a little bit more time, perhaps in the clinic or through telehealth or through MyChart messaging in the UCLA system. So we have a little bit more time to do a deeper dive and look into where the limitations are and where the roadblocks were for that particular patient. And then hopefully go back and be able to provide the education to the patient that this is where the limitation fell, this is what we're doing to circumvent this problem, and then go from there.
I think that the nurse-patient relationship is so important as well, and you nurses are truly the heart of the center.
Obviously, we're looking at the patient from the physical aspect, but as a nurse, we need to look at the patient in their totality. How are they affected psychologically? What's going on with them emotionally? Where's their educational level at? What is their social situation? And how is their financial aspect influencing all of this in terms of access to healthcare and their ability to receive the medications and the therapies we're talking about? So we try to look at each patient individually, obviously, with the strengths and the weaknesses and what we can do to provide resources or to target our energies and efforts to overcome some of those challenges that the patients are faced in the various aspects.
Being diagnosed with heart disease in general can be expensive, and let alone heart failure. Right. So what can you tell patients that are limited in their resources?
Right, that's an excellent question. First of all, if they're within an HMO, it's really important that they have a good primary care physician, that they have a good rapport with their primary care physician, because the primary care physician is essentially the gatekeeper to have them get access to medications, therapies, and the appropriate resources within the healthcare network. So they need to have that established. It's important that the patients share with us what limitations that they have. Obviously, some medications and some therapies are more expensive than others. And when patients say, I can't afford that, even though that is a guideline-directed medical therapy, we can either go with an alternative that is affordable, and then we can also look at resources that we have, whether it's through the pharmaceutical companies or prescription companies that can offer different plans that make some of these therapies more affordable. And at UCLA, we're also very lucky in that we have access to our specialty pharmacists that can help us write the necessary authorizations in the language in order to have these patients receive therapies. And what we've seen is oftentimes when patients are limited in that the medications are not affordable, many times it's come back that authorizations were not placed, the language was not used correctly, and so they've been denied that medication therapy. But if we know that ahead of time, we can go in and provide the necessary documentation that's needed so that they can get these life-saving therapies.
Well, I think it's so interesting what you mentioned around finances, because when you're given a diagnosis, you think, oh, I just need to bootstrap it, figure out a way to pay for these medications. But you're telling us that there are ways that people can get additional help through the pharmaceutical companies, or how can they get additional help financially?
There are different avenues and different resources, and there are different drug companies and prescription companies out there that do offer discount on the prescriptions. I will say, though, there are complete financial limitations. And despite going through these different avenues, there are still constraints, and the patients can't obtain the medications. So then we have to reach out to what resources we have within UCLA to see. Sometimes patients have to fundraise. Sometimes we have to go through different channels with our pharmacists to see how it can be made more affordable. Or we have to go with the alternative medication that can still provide a benefit, but maybe is not at the top level of benefit for that patient because of the financial constraints.
Is there anything else regarding finances and the patient experience that you can share with us?
I think it's just really critical that the patients know their plan. The patients really have a good understanding of their health insurance. And health insurance is complicated for all of us, right? And there are so many roadblocks down the road that many times people are like, it's too confusing, I'm not going to get involved. That's not the best way to handle it. Patients have to be involved with their insurance. They have to know where their limitations are, what they're going to be provided, what their out-of-pocket expenses are. Because at open enrollment in November, maybe that's the time that the patient actually should be looking at other alternative plans or other options to them that maybe they might have a higher copay or a premium, but they have better access to certain healthcare systems and or medications.
So being a patient myself and recently divorced a few years ago, I was obviously very nervous about healthcare and health insurance because I was on my now ex-husband's plan. And I'm now doing Cal Cobra, and it is so overwhelming having been through the process. And so I'm wondering, what advice do you have for us? Because my Cal Cobra is going to expire pretty soon here too. Yes. And it is a hefty monthly bill as well. So what can we do as patients? Like when you say to understand our policy, how do we do that? It's so overwhelming.
There are financial counselors available to patients, not only through the health care network of their insurance company, also within UCLA. So when patients come to me and say, I have to change plans, but I have an option of three or four different plans, I always want to direct them to the correct financial resource people at UCLA so then they can tell the patient, yes, we're contracted with this. You can see us. No, we are not. This requires an authorization for every single visit. I don't have that depth of knowledge. Right. So I would want to hook the patient into the appropriate resource person that can provide that information.
Now, we've talked about the finances, and what else does a nurse offer these patients?
We're all very professional, and we really pride ourselves in the communication that we provide to our patients and the ongoing communication with our patients and their education over time, whether they're newly diagnosed and unbelievably stressed, or they're doing so well and very stable, and we don't see the patient but once or twice a year. So we want the patient to know that they can have a good rapport with us. We can relate to them as an individual in that we view each patient individually. And what can we do as a nurse to make the experience better?
Being this heart failure patient for, my goodness, for 20 years now, there's shame and blame when it comes to heart disease. So that's why I coined this phrase, heartquake, or trauma of the heart. When you think of that word heartquake, does it mean anything to you being a nurse who works with heart patients day in and day out?
You know, that's interesting because I've never heard that term. And we don't view any of our patients with a shame or blame. And I actually think since heart disease is so prevalent in the United States and in the world, I personally don't see that. I think as healthcare professionals, we're so proud to be a part of cardiovascular and cardiac care and heart failure care.
You know, you wonder, did I eat wrong? Did I do something wrong? And so whereas with cancer, it feels like there's finality there, right? You go through chemotherapy, you're in remission. Whereas with heart disease, this is a lifelong disease.
Well, that's why we also don't call ourselves the heart failure clinic. We call ourselves the cardiomyopathy clinic.
Yeah.
So I do think that there's certainly an aspect of lifestyle and personal habits that can contribute to many of the patient's cardiovascular problems. But there are a lot of cardiovascular diseases and a lot of different etiologies of heart failure that are not to be blamed upon someone's lifestyle or someone's behaviors in the past. So you can't negate it entirely, but there are also other aspects. There's genetic aspects, we don't have control of.
Thanks for watching Heartquake Media. Make sure you check out our website and social media for more information on heart healthy living. And remember, wellness starts with the heart.